which will be on Wednesday, September 28th at 8 a.m. Dr. Ann Stroink, the current president of the AANS, will be joining us. So we're looking forward to that important milestone in the year. And today, for this Grand Rounds Hour, we have Dr. Coppell, who is a professor of neurosurgery, neurology, neuroscience, and psychiatry, and the director of the Center for Neuromodulation at the Mount Sinai Health System. He's also the co-director of the Bonnie and Tom Strauss Movement Disorders Center. And as you can tell from his titles, he focuses on the applications of neuromodulation for neurologic disease, including most notably movement disorders and psychiatric disorders. And that's what he'll be speaking to us about today. He completed his MD from NYU, followed by his residency there and fellowships also at NYU, but in Switzerland at the well-known University Hospital in Zurich for stereotactic and functional neurosurgery, and at the Cleveland Clinic and in Ankara, Turkey. He's done probably more DBS procedures than anyone in the city and possibly anyone in the region. And has been working over the course of his career to make the procedure safer and more efficient for patients to undergo. So he'll be speaking to us about developments in treating obsessive compulsive disorder in deep brain stimulation, with deep brain stimulation.
All right, Peter, thanks very much. Thank you for inviting me to talk today. Those of you, many of you might know, but in case you don't, one of the organizing interests of our group over at West are non-motor phenomenologies and how we can use neuromodulation to treat them, whether it be non-motor in Parkinson's disease or frank psychiatric phenomenologies in OCD and in depression. And so today I'm going to give you an update of our work utilizing connectomic DBS for both OCD and major depressive disorder. This is my disclosure statement. So I'm a consultant for these three industries.
Share your screen, Brian. We can't see it yet.
Oh, I'm sorry. Don, I thought I did. Yep, here we go. Again, my disclosure statement with these industries. So, what is the biophysics of DBS? Essentially, axons and fiber tracts are the most sensitive element of the particular neuron to extracellular stimulation, which is essentially what deep brain stimulation is. So the fact that axons and fiber tracts are the most sensitive element, it would make sense that this would be the way that we would organize our targeting in order to maximize our benefits from DBS. One of the things that axonal fiber tracts allow for is something called anisotropic water flow. Essentially, axonal fibers are tubes, and tubes only allow water to flow in a single direction. We can take advantage of this utilizing a technique called diffusion tensor imaging, which allows us to track the flow of water along these tubes. And this allows us to define the structural connections between various anatomical areas in the brain. And this tractography is called the connectome. These networks that the connectome defines is in essence the true target of our DBS procedure. And so from there, we get something called connectomic DBS. So let's start off by what has been going on in OCD. So if you look at the literature for OCD that's been around now for 20 years, there are a whole host of quote unquote targets for DBS for OCD. The ALIC, the Bedstria, the STN, the GPI, the nucleus accumbens, and they all sort of coalesce in a relatively limited anatomical area within the ventral striatum. But nonetheless, there's not a lot of specificity about where these groups have finally converged. Not surprisingly, there is a variance in responder rate, a variance in response time. And I think that reflects the idea that our targeting, at least historically, has remained ambiguous. You know, the target itself is a outgrowth of the old anterior capsulotomy procedure, a lesion made in the anterior internal capsule. Now, this is a big structure. You can see here, it's a huge structure. Where can you target on this? And, if given the fact that fiber tracts are the real sort of element that we're stimulating, that's a long area to stimulate. So where along this do we approach? Moreover, if you actually, from a sort of anatomical standpoint, it looks like a relatively simple sort of structure, but the actual sort of internal anatomy of the internal capsule, this is a coronal view, you can see from dorsal to ventral, medial to lateral, there are a somewhat complex anatomy of how these fibers travel within the internal capsule. And you have to take into account where your electrode is along this structure. Otherwise, you might have differential effects. One of the sort of empiric observations that have occurred in this field over 20 years is that there's been this sort of steady march posteriorly along the capsule from the original capsulotomy target along this structure. So that suggests that fibers in the more posterior aspect of this anterior limb of the internal capsule may be more important to getting a good result. However, how posterior is too posterior? At some point in this capsule, you begin to lose the connections specifically to the frontal lobe, and you begin to preferentially stimulate midbrain fibers or thalamic fibers. So again, too posterior, and all of a sudden you're beginning to lose certain critical elements. So where along this tract is a really important area to discover. In 2020, our group took a look at our group of patients that have undergone DBS for OCD using a standard anatomical position targeting scheme. And they found indeed that the responder rate was about 73%. My graduated fellow, or our graduated fellow, Josue Chasen, while at Madrid, also took a look at their results, and their responder rate was 78%. So Josue had a really good idea, is to take a look at our group along with this group, since the response rate was slightly higher than what was typically reported in the literature. There may be some common elements that we could pick up and play off of prospectively to try to do better in the future. So Josue took a retrospective analysis of 20 patients from both of our centers. And again, the reason being is that there was some similar and sort of higher than normal outcomes of these groups. These were very sick patients. Generally speaking, if you have a Y-box score over 30, which is the scale for the OCD phenomenon, you're very, very sick. And these patients had a very significant follow-up of 2 to 4 years. And so there are two methods of analysis that we use to look at these retrospective analyses in order to create a prospective surgical strategy. The first one is to look at the so-called sweet spot of clinical improvement, and I'll explain that in a minute, as well as the connectomic maps of the clinical response. So let's first talk about the first type of analysis, the sweet spot of clinical improvement. So the first part is localizing the electrodes in a particular anatomic region. But remember, ultimately, the electrode itself isn't what causes a change in the neural network. It's what we call a volume of tissue activation. So it's not just so much the tip of the electrode itself, but it is the actual geometric volume of the tissue that we are stimulating, and that's based on the stimulation parameters that we choose. That is the sort of true implant of the procedure. And so what we do is we correlate the volume of this tissue that is activated with a percentage of change in the particular behavioral scale that we're measuring, in this case, the Y-box. And so the result of this analysis showed a sweet spot, or a very critical area just at the dorsal border of the GPE and the most ventral portion of the anterior limb of the internal capsule. And you can see that there is this very sort of hot spot correlating the improvement in the Yale-Brown Obsessive Compulsive Scale with the volume of tissue of activation. So that gave us our first clue as to where we should begin to look for white matter connections. The next step is to look for such connectomic maps in this region. So we utilized a technique called constrained spherical deconvolution probabilistic tractography. This is a type of tractography that's a little different than most people in neurosurgery sort of intersect with. For tumor applications, typically it is used deterministic. The reason why we use a probabilistic tractography is because we have so many smaller fibers that cross over each other, and we need a different type of imaging technique that can help resolve how these fibers flow when they begin to cross over with each other. And so the idea is that we take that hot spot, that volume of tissue of activated that we saw in that first analysis, and we send seeds from that area to see which white matter connections traverse that particular VTA. And then we begin to develop something called common maps of both responders and non-responders. And remember, in OCD, if you have a greater than 35% improvement in the Y box, you're considered a responder. And so the idea is this development of a common map. Now, I have to give credit to my colleagues, Dr. Ki-Sung Choi and Helen Mayberg. This is sort of the essence of their work down in Emory that has unlocked depression, but the development of something called the common map. And what is that? Essentially, you take all the responders, for example, and you group them together, and you only take the tracks that they all have in common. So if there's a particular track that only 1 out of the 5 responders have, but the other 4 don't, that's eliminated. So all of the tracks that are in this common map are common to all the responders. And the inference is that if this is in something that all the responders have, that those tracks are pretty critical to the response that we're trying to get. And this can also be applied to the so-called non-responders to look for the tracks that are particular to not achieving the behavioral effects that you want. And so based on this analysis, we looked at those 20 patients and we found that there are critical connections between the area of that hotspot and the dorsal medial prefrontal cortex, the ventrolateral prefrontal cortex, the pallidum, the ventralis anterior and the dorsal medial nucleus of the thalamus, the orbital frontal cortex, as well as the subthalamic nucleus and the VTA regions. Also, very interestingly, is what were the connections of the so-called non-responders? You can think of this as like sort of the anchor on the system, you know, that if you pick up these fibers and connections, that you may be likely hurting your response in terms of the behavioral effects. And primarily, these are connections that are going into the amygdala region. So how do we put it all together? We have to somehow take the connectivity maps that we've developed and the sweet spot that we've analyzed and bring it together in some sort of cohesive strategy going forward so that we can help build on this knowledge. And so within the connectomic areas of the internal capsule, there are kind of like 2 major highways within the ALIC. A medial division that's biased towards the thalamus and the medial prefrontal cortex, and a lateral division that's biased towards the ventrolateral prefrontal cortex and the STN regions. And so the sort of prospective strategy that we created from this analysis and that we've used over the last 1.5 years is that we put a burn mark, and this is essentially a sort of a computer created voxel within an imaging sequence that we use in the operating room in the anterior limb of the internal capsule that exists between the medial and lateral subdivisions of these two connectomic highways that we've sort of stratified in the anterior limb of the internal capsule. And then we place an anchor point within the anterior medial GPE, which is the sweet spot of the VTA that we saw previously. Because remember, when you place a DBS lead inside the brain, it's not just the target point that you're trying to hit, but you also have to consider the trajectory along the fiber tracts that you're trying to stimulate, because the angle of attack is really important in terms of which fibers you engage with. So the burn mark and the anchor point together creates a trajectory and targeting scheme that we can use on a patient prospectively to ensure engagement with all of the key anatomical regions that we have identified. So here are some preliminary prospective results. We've had 5 patients implanted using this new prospective connectomic-based approach. So far, 3 are responders, which again is a greater than 35% reduction in the Y box. 1 is currently a non-responder, although over time they may respond. They're really close to responding, but for the analysis of this, we brought them out of the analysis because they didn't quite hit 35%. Also not in this analysis is 1 patient that was explanted at 3 months due to hardware erosion. But by 3 months, he was already a responder with a 46% reduction, which is a pretty healthy reduction. Anecdotally, these patients that utilizing this technique are responding within weeks of stimulation, which is quicker than our previous group. We'll have to wait and see if that holds off. So here is our common responder map using prospective data. And what was gratifying is that, once again, we are seeing the same anatomical areas that we identified previously. So there were no surprises. We're engaging indeed with this technique of these critical areas that we think are really important to have a consistent response for OCD. Going forward, we're going to have to add more patients to this common map to see if it improves in any way or if other things are come out. One of the other forays that we're going to be doing with these patients, utilizing 7T tractography, we have developed a model that shows that directional DBS leads. We have DBS leads now that can stimulate in various different trajectories, not just in a circumferential manner. And so there is data to suggest that we may be able to stimulate these selective anterior limb of the internal capsule pathways that I showed you previously. And so we may be able to differentiate certain symptom relief based on which segment of the DBS lead we stimulate. And again, we're going to be looking at 20 patients with this approach as well. The devices that we're implanting are the so-called Medtronic Percept device. This allows us to record local field potentials in the areas that we are stimulating. And we are going to follow these longitudinal recordings during the course of recovery, hopefully to show us a biomarker of improvement that will help simplify and stratify programming. In addition, on top of this, we are doing cognitive tests outside of the operating room, along with high-density EEG to look at cortical areas that are being stimulated during chronic stimulation, hopefully to get a better sense of which cortical areas these white matter tracts are engaging with. So stay tuned for more of this in the future. I'd like to now pivot about how connectomic DBS has affected major depressive disorder application. So my partner, Helen Mayberg, this is her seminal work in 2005, where she found that there was a very specific pattern of metabolism in an area called the subcallosal cingulate that was hyperactive in patients that were untreated depressives, and that this area went from hypermetabolic to hypometabolic with successful treatment, whether it be medication or cognitive behavioral therapy. But it basically indicated this was a critical region in the development of the phenomenology of major depressive disorder. And so based on this, in 2005, along with Andres Lozano in Toronto, they did the first study of DBS in this region for treatment-resistant depression, and 4 out of those 5 patients did well, and that really sort of ignited the field. This ultimately led to a industry-sponsored study called the BROADEN study that was initiated in 2008. It was started by St. Jude Medical. St. Jude is now Abbott. It was 15 centers. There were 200 planned patients to be enrolled in this. It was a double-blind and sham-controlled 6-month endpoint study where the response rate the target was a 40% response rate, and a 40% response rate was defined as, or the response rate itself was defined as a 50% reduction in the MADRS, which is a depression rating scale. However, a futility analysis in 2013 that was conducted by the company projected only a 17% chance of success after 90 implants. And they made the corporate decision to halt the trial because 17% didn't seem like a good economic reason to continue on. However, a long-term follow-up of these patients over 2 years demonstrated easily a 50% response rate at 2 years. Now, obviously, that's a post hoc analysis, but it certainly makes you scratch your head and wonder, did they, in fact, pull the trigger on that futility analysis too early? But more importantly, I think another more important question is why did they fail to meet success in this particular area? Well, one of the critical things about this trial, and this was sort of earlier in the time of DTI, we didn't have quite the tools that we have now. It was all based on anatomy-based targeting of this region rather than connectomic-based targeting. Why is that important? Well, so if you looked at the sort of anatomical positions of responders and non-responders, there was no real clear anatomical landmark, no statistical difference between responders and non-responders in an anatomical location that was normalized to like a normalized brain like the MNI. So if anatomical location itself cannot predict outcome, there's got to be another way that we can sort of differentiate responders for non-responders. And this is where Helen led the group in Emory to create a connectomic-based target selection of this region. So they worked at it. You know, again, you have to give Dr. Mayberg a lot of credit. A big sort of public quote unquote failure of a pivotal trial of a particular technique would often dissuade a lot of investigators to move on to something else, but she didn't. She dug in, and along with her group, they developed a common map technique that I described earlier, and it revealed a set of pathways intersecting at the subcallosal cingulate. And this set of pathways includes the following: the forceps minor, which are the white matter pathways intersecting with the various prefrontal cortical modules, the cingulate bundle, the uncinate fasciculus that connects the frontal lobe into the amygdala and the anterior temporal regions. And then there is a fourth area that connects these frontal regions to the striatal region, the nucleus accumbens, and the midbrain. And so they started to look at 2 different cohorts that use the classic anatomical-based targeting and this new connectomic-based targeting. And lo and behold, what they found that the 6 months response rate improved 31% with this connectomic response, which is a huge difference, much larger than I think that they were anticipating. But it was a real aha moment. And based on that, Ki-Sung Choi has been looking at the BROADEN patients that still are around, that are still implanted, and that there is a complete data set with. And what he did was he looked at their anatomical positions. Now we didn't have individualistic tractography data for these patients because again, they were implanted prior to essentially DTI reaching sort of more maturity. But we were able to look at the data, or he was able to look at the data in relation to a sort of normative group tractography data set called LEAD DBS. And what they found is that the patients that remitted, essentially were cured of their depression, had the complete 4 pathways. The responders that did pretty well, but weren't completely remitted, had incomplete forceps minor activation. And the non-responders had either no or incomplete cingulate bundle activation. So based on this, based on the fact that at the 2-year follow-up, patients had a tremendous response rate, Abbott went back to the FDA, and on July 12th of this year, was granted breakthrough designation for the use of deep brain stimulation in the subcallosal cingulate, which is going to allow a limited release of this to about 20 centers, along with a post-market study. And this is a really, really big step in bringing this ultimately into the clinic out of the investigational phase. And that's all through the insight of connectomic DBS. So in conclusion, it's extremely clear that connectomic-based targeting, patient-specific, is really key to unlocking the application of deep brain stimulant for psychiatric applications. With regards to OCD, an emerging connectome involving the OFC, the ventrolateral prefrontal cortex, the dorsal medial prefrontal cortex, the STN, the ventral tegmental area, and the thalamus, along with the associative palatal-thalamic pathway, is emerging. And with more patients utilizing high-density EEG techniques outside of the operating room and chronic LFPs from these implanted patients, we believe that we were going to be able to elucidate this connectome further to improve our historic results. And in terms of major depressive disorder, connectomic DBS has essentially allowed something to go from a failure to a breakthrough designation by the FDA. Obviously, this work it involves a heroic effort of a lot of people. I am so utterly gratified that I work with this group of people every day in order to help work on these problems. I am very, very fortunate. So I'll open this up now to questions. If people would like to ask questions, I'm happy to do so.
Thank you. It was beautiful. I'll start off with a question.
Sure.
The circuitry is likely to be complex, and as your understanding of the anatomy grows, you're proving that. The stimulation still seems to be rather crude relative to the connections that you're likely to be influencing. Is there any thought to future technology that might greatly enhance the complexity of what you're able to do stimulation-wise, and distribution, anatomy, resolution, et cetera, et cetera?
So I think speaking to that point, I mean, obviously, as you well know, like the FDA doesn't do any of us favors in terms of bringing new technology to market. It is just a glacial pace. But that being said, we do have this tool of segmented DBS leads, where previously DBS leads were essentially 4 contacts that were essentially cylinders stacked on each other. And the cylinders were only able to generate a volume of tissue of activation that was fairly homogeneous, like a sphere. These new segmented leads, where the cylinder is now cut into thirds, based on our modeling, looks like that we may be able to reach out and pull on certain particular fiber tracts in a preferential way than others. That certainly will begin to help us, give us more granularity of control if it works out. And then obviously, if that works out, then the companies will see some sort of quote money in that, and then you'll see more different configurations of that type of segmented leads.
Great.
Brian, that's really exciting about the breakthrough designation and the work you guys have done to contribute to that. Are you able to evaluate effect with connectomics? Are you able to repeat the connectomic study later and see changes related to the DBS?
Well, so the idea is not so much that the stimulation is going to change because these white matter pathways that we're picking up are not going to be sort of responsible for neuroplastic changes in the brain. That usually happens at the level of the synapse and the dendrite, and that's at least currently way beyond our sort of resolution of imaging. However, you can utilize that connectome, if you will, and correlate that with the local field potentials that we're recording subcortically from the implanted devices, as well as the high density EEG signal that we're getting chronically as well, outside of the operating room. And those signals presumably are going to be directly affected by that connectome that we've targeted, right? Because when you stimulate those white matter tracts, signals go out, and that's going to obviously differentially affect the high density EEG signal that we're picking up. So as far as that's concerned, that's how we're utilizing it.
Cool. I see a question from Trevor.
Yeah, Trevor.
Hey, Trevor, or is your hand up accidentally? Maybe accidental.
Can you hear me?
Yes, we can hear you.
Yes,
now.
we can. Yeah.
Oh, sorry about that. Yeah, this is great, Dr. Capel. My question would be, looking at OCD and depression, what other psychiatric disorders do you think would be the next on the frontier that we could look to apply this technology to?
Obviously that's a good question. It certainly begs the question. My personal belief that I would prefer to see we're not even close to being done or even satisfactory in any of these two entities yet, OCD and depression. So my kind of feeling is that I would prefer to see the field dig further down into depressive disorder and OCD than to sort of go off in a foray of other areas. I think that the basic sort of connectomic understanding of other psychiatric diseases like PTSD or schizophrenia are far more complex, and there are pilot studies that are looking into that, but I'm not sure that necessarily serves the field well. However, I think as a converse to that, we're also really interested in looking at non-motor phenomenologies in our movement disorder patients. So remember, psychiatric disease is a continuum. The depression and OCD is very often found in patients with Parkinson's disease. That's got to have common elements with classic OCD and depression. And if we're able to sort of treat those symptoms in the same way that we treat the motoric symptoms of Parkinson's, and we understand the connectomic sort of underpinnings of that, that might in fact help the whole field of psychiatric neuromodulation in a way than just going into a new field is, a new disease area.
Thank you.
Yep.
You want to relate that to satiety, obesity, addiction, the related peripheral things? Yeah,
so, there has been over the years, like for instance, obesity. I have a very, schizophrenia, I can see where this technique might be very helpful and useful because the pharmacotherapy of schizophrenia is really not very good. Obesity is a little different, Josh. Despite that there are forays of looking to do obesity DBS, I personally feel that that obesity is much more of a neurometabolic problem rather than a strict circuit pathology. And, especially, I don't know if people follow this. I have a particular interest in this particular area from a variety of things, but there was a recent New England Journal article looking at semaglutide, which is a GP1 agonist. It's a once weekly injection, but they are now basically showing weight loss in overweight people and in obese that is just about equivalent to bariatric surgery. And so if I read the tea leaves correct about obesity, it is very likely to be a true medical sort of interaction rather than something that requires brain surgery. That's a separate thing. But in terms of schizophrenia, certainly the pharmacotherapy of schizophrenia is not very successful. And that's obviously, looks where neuromodulation might be improving that.
How about addiction?
Addiction is another good particular area. I happen to be the chair of a DSMB of doing DBS for the nucleus accumbens that's currently being done at West Virginia. It's certainly promising. It's a terrible disease. I do think that that's an area that is going to emerge. I think the connectomic work that we're doing with OCD is very relevant to it because it's in the same region, Josh. So in other words,
Right.
I think they're going to feed into each other. And that may, in fact, what we're doing with OCD may actually inform that process as well.
Great moment to be in your field.
It's fun. It's definitely fun. Any other questions? I think there were two in the. Can you redo this lecture with patients telling us their experience? Generally speaking, patients with these disorders tend to be a little bit shy about showing their faces. I think that it shows that there is still a stigma of psychiatric disease. Nobody would feel bad necessarily about saying, hey, look, I've got Parkinson's disease. But for some reason, there is still this stigma of psychiatric disease. One of the things that I hope that neuromodulation does do is show people that there's really no difference between a tremor and an OCD as far as your brain is concerned. They're both circuit pathologies and they shouldn't be stigmatized. There's another question. How long do you think it will take psychiatrists who employ classic therapies, medication, cognitive behavioral therapy, et cetera, to feel comfortable with their patients getting this type of approach? I think it actually be a lot quicker than most people think. Number one, take a look at like how transcranial magnetic stimulation has really taken off. That's an indicator that people are really interested in alternatives to what is going on. Number two, the pharmacotherapy pipeline for these entities have largely dried up because of lack of efficacy. You can also see the pivot towards psychedelics in this area. People are really, really interested in these alternative therapies. So I suspect that the pivot, if we can show really good efficacy data and that it's safe, I think people will accept it.
How long do you think it took for movement disorder neurologists to begin accepting DBS when it came about? And granted, that was the first application of DBS, so it's a little bit different, more of a hurdle, but
there's that, and obviously movement disorder surgery has been around a long time. This is just my opinion. I'm not stating facts here. In my working with both movement disorder neurologists and psychiatrists, they're sort of different phenotypes, and I think that there's maybe a little bit more of a conservative bent, believe it or not, to some movement disorder neurologists compared to psychiatrists. If you look at the history of psychosurgery, the psychiatrists just in general are surprisingly more aggressive, and even though they may say otherwise, their behavior suggests that they actually pivot fairly quicker to these breakthrough type of therapies. We'll see.
All right, well, I don't see any further questions or hands raised. So thank you, Dr. Coppell, for this presentation today, and thank you everyone for listening and participating. And we will see you next week for the post